Good afternoon. Probably a couple of preambles before I begin. One of which is I was asked to talk about the evidence. There is actually quite a lot of it. I'm only going to present a fairly partial slice, and even then it's difficult to give full detail. I did yesterday prepare a Twitter moment which contains most of the references to the key sources that I'm citing. So if anybody is following the Twitter feeds for this, I will repost that with the hashtag after I've spoken. So if there's anything you want to chase up, you should be able to follow it from there, or otherwise make contact with me via Twitter. My Twitter handle is on there. The other thing that Anne sort of mentioned work that I've done with various bodies. I do have to issue a disclaimer, which is to allow them to disown me and anything that I say at this point. I mean, the work that I'm going to present has been supported by lots of bodies, but what I'm going to say is very much what I believe, my thoughts, my analysis. I try to keep neutral on this as far as possible, but you know, sometimes I get a bit impassioned, and probably after lunch that's probably no bad thing. The other thing is I'm not quite sure if it's truly an apology, but I think we've got to recognise that in recent years safe staffing has almost become synonymous with safe nurse staffing, and I suspect many of you, but not all of you, when you signed up, that was what you were expecting, and for most of the rest of you that was what you feared. But equally I'm very aware that this conference doesn't specify a particular staff group, nor does my topic, nor does it specify any particular healthcare setting. Given that the brief is just multiplying sort of legion, I'm going to be a little bit unapologetic. I am going to focus on evidence around safe nurse staffing because that is a vital issue, and because it illustrates the challenges that are shared by many professions, and actually everybody working in healthcare should have a stake in safe nurse staffing. I'm going to focus on evidence linking nurse staffing to outcomes on hospital wards as well. It's a key group, it's a large driver of resource, it's clearly really important, but it's also where the vast majority of research lies, although I am going to touch on studies and findings in other areas, albeit really briefly. But I think one of the things we've got to recognise is that, you know, there's another issue about nurse staffing which I think has driven a lot of this research, and it's why nursing ends up finding itself in a stronger position with a research base, is that actually, ironically, the contribution of nursing to patient safety, or indeed any outcome, it has historically often been neglected. And I think particularly the input of other professions, and I think where I say other professions, what I really mean is doctors, that's taken for granted. The essential role of doctors in delivering healthcare is absolutely taken for granted. And when you look at the business of delivering care in a hospital, they're seen as essential to the business. By contrast, nursing has often figuratively and sometimes literally been counted as part of the hotel services cost of a hospital. And so establishing the crucial role of nurses in patient safety, I think, has been a research imperative. But my limited focus is largely dictated by the available evidence. And I think, sort of despite that, I hope that we can all identify that there are some wider lessons that any profession can learn from. And insofar as I'm driven by a gap in the evidence, or I'm driven here because this is where the evidence is, if you can see gaps relating to your profession that we might fill with similar things, I'm absolutely up for it. You know, my business is not safe nurse staffing. I do have a certain expertise, but actually, you know, I'm happy to extend the scope of what we do. But I think one of the big issues as well is how we actually respond to evidence like this, which is effectively a workforce epidemiology to make decisions that have huge economic and clinical consequences, but are inevitably surrounded by huge amounts of uncertainty. I'm also going to focus on staffing levels. And there's an awful lot more to safe staffing than the numbers. I absolutely admit that. And I think you can get the impression that people are often searching for a magic number that guarantees safety. Now, I think I'll give you a warning. I'm not going to give you one. That actually ought to come as a relief. But equally, although we've got this focus, I think if you go back through inquiry reports around this topic over many years, it's very clear that that link between nurse staffing and patient safety hasn't been recognised, and far from having a focus on a magic number, I think that trusts have proceeded as if the numbers don't matter at all. So we have to start somewhere, and I think I would argue that having the right number of staff is a necessary but not sufficient precondition for safety. There is another way of looking at this. The link between nurse staffing levels and patient safety was recognised and was researched well before the events of Mid-Staffordshire, which has put the topic of safe staffing on the NHS agenda. But for many of us, it wasn't news. But as I say, when you read the inquiry reports, one can only conclude that those who were delivering services in that trust were either unaware or willfully ignorant of what was already then quite a substantial body of research. If they knew it and were aware of it, they felt compelled to ignore it for some way. And I think one of the positive outcomes of these inquiries has been to link safety and staffing pretty inexorably. One of the downsides is that it's done that to such an extent that I think sometimes people dismiss research in this area as simple restatements of the obvious. And we've got a couple of comments on this slide, and I offer them because that's often the response to the publication of new research findings. And in fact, these have been said in the last few months about my research. Interestingly, I prepared the slide, or I've used this slide for a couple of years, and that predictably, every time we publish something new, we get the Sherlock comment. So, and as soon as I posted the research this time, I waited, I think, about 35 minutes before I first saw it. More politely, though, we look at the dates on these reports. In 2010, the Royal College of Nursing described research linking nurse staffing levels to patient outcomes as compelling. Way back in 2005, the US Joint Commission described the evidence as overwhelming. Now, one of the results of the Francis inquiry was that NICE was charged with preparing safe staffing guidance, as I'm sure you all know. And our team in Southampton were commissioned to do the evidence reviews for NICE. Now, a very brief summary of the evidence. I apologise, having sat at the back all morning, I realise it's actually very difficult to read the slides from the back. The ones in the big boxes are what's important. In terms of what we know, there's a really consistent evidence base showing an association between registered nurse staffing levels and a range of outcomes, including mortality. Estimates vary across different studies, but a 6% increase with every additional patient per registered nurse on a general ward is pretty typical. Also see lower reports of missed nursing care, omissions in essential care, fewer falls and shorter hospital stays. There are some areas where the evidence is a little more mixed, probably because of difficulties in risk adjustment. If you look at the issue of skill mix, the proportion of registered nurses within the nursing team, you get pretty much the same set of results. A skill mix that is richer in registered nursing is associated with a range of better outcomes, including reduced mortality. When you look at results that are about adding assistant staff to the nursing team, though, you get actually some quite perplexing findings. And to summarise that evidence, there is absolutely no indication in the evidence that adding assistants to the nursing team delivers benefit. And there is some evidence that it creates harm. A thought that you need to hold on to for a bit, because that is a perplexing finding. NICE, though, came to the conclusion that there is a lack of high-quality studies exploring and quantifying the relationship. Now, our review was based upon hundreds of studies. So when they say there's a lack of high-quality evidence, we've got to try to understand exactly what that meant. Unlike many areas, the issue is not a shortage of actual studies. When we did our review, there were literally hundreds of studies going back to 1993. Some of those studies, in fact, many of them were very large, covering hundreds of hospitals, millions of patients. But all had some significant limitations. Most crucially is that almost all of those studies were cross-sectional studies. So in effect, they look at the association between an average staffing level over a period of time with an average outcome, typically at the level of the whole hospital. Another key limitation for NICE was that there was essentially no economic evidence from the UK. So, we're now in 2019. So where are we now? Well, things have moved on a bit. The overall picture in terms of the established associations really hasn't changed. My little note for myself says has not changed dramatically, but thinking about it, I don't think it's actually changed at all. We have seen more cross-sectional studies, including more results from the International RM Forecast study that was conducted across several hundred hospitals in Europe. Here we've got some of the results showing the effect of a 10% increase in skill mix and the effect of adding 1 registered nurse per 25 patients. That's approximately sort of 1 nurse per shift per ward. And what you see is that both higher skill mix and higher registered nurse staffing are both associated with improvements across a range of outcomes, including mortality, patient experience, nurse job satisfaction, and staff burnout. Essentially, that's more of the same. We are starting to see evidence emerging that is addressing a number of the important limitations and uncertainties that arose from the NICE reviews. One of the limitations that we identified with NICE is that there is a relative lack of studies from the UK, and because staffing is very context dependent, that did seem like it mattered. Also, a lot of those studies just report overall associations rather than focusing on particular staffing levels, which is also problematic. So as part of the work that was commissioned by NHS Improvement to support their safe staffing work, I quickly gathered together all of the UK studies that reported a staffing level. And this slightly confusing looking graph tries to sort of summarise what we found, and I'll just talk you through it. As we go from left to right on this graph, what we see is staffing levels reduce. So it's at the bottom of the graph, what we've got is a patient to nurse ratio. So as we go from left to right, nurses are on average caring for more patients. And on the left is a scale of risk, and they've got a variety of different outcomes that have been measured in the study: mortality, burnout, low quality, surgical mortality, length of stay, and a decline in nurse perceived quality. What I hope that you can gather from this confusing graph is that as you go from left to right, the lines pretty much all go up. They're not all straight lines, they're a bit wonky, but they all go up, saying that outcomes are getting worse as staffing level is lower. You can see that there's a slightly artificial sense that different outcomes are on slightly different scales, so I wouldn't read too much into that. Where and when and exactly they go up varies across the different outcomes and different studies done in different settings, no great surprise. And then I mapped a dotted line in the middle. The dotted line in the middle is the magic number that NICE identified of 8 patients per nurse. Now, what I hope that you can see is that once we have exceeded the magic number of 1 to 8, pretty much all the outcomes have indeed got worse. But I defy anybody to look at the graph without the dotted line and say, the point at which things start getting worse is 1 to 8. That's just not the case. So one of the things that I think we can reiterate from this data is what NICE really said about 1 to 8, which is it is a point at which harm is known to be occurring, or at least the risk of harm is substantially increased. It certainly shouldn't be interpreted as a safe or desirable staffing level. That's absolutely not the case, and the evidence on this graph really should tell you that. One little note of caution was that the recommendation from NICE was focused on an individual shift, and here we're looking at hospital level averages, albeit in similar units. So the mapping across from the two doesn't mean that you necessarily, absolutely, should have an alarm bell going off the moment one shift goes over 1 to 8. But I think it certainly gives no support for that as being a safe staffing level. It gives support for that being a real warning indicator. So that's new. The other thing is I'm going to share with you briefly results from our latest NIHR-funded study, which was reported in December. This was a longitudinal study based on data collected over 3 years from 32 wards and 138,000 patients in one hospital trust. And it's really different because it is longitudinal. It goes patient by patient, day by day, looking at the staffing levels that those patients were actually exposed to. The hospital is in many ways pretty typical. If you extrapolate from an hours per patient day measure, on average, across 24 hours, registered nurses are caring somewhere between 6 and 8 patients per each on most of the wards. The skill mix is a little over 60%. I would take a guess from most rooms I'm into. I've presented these sorts of things in. There's a bunch of you are thinking, that's really low, and there's a bunch of you that's thinking, that's really high. So it's there or thereabouts. I think it's probably on the low side of the normal range. And on this graph, we plot the relationship between registered nurse and healthcare assistant staffing levels and the risk of death. Here, as we move from left to right, the staffing levels, now measured in hours per day, increase. And the staffing levels are measured in hours per day relative to the norm for the ward that the patient is on, because we all know that different patient groups, different wards have different staffing levels that are required. And if you follow the blue line, which is registered nurses from left to right, you'll see that the risk of death decreases. And that's about 3% for every additional hour of registered nurse care over the course of the first 5 days of the hospital stay. So that's not an hour per day. If somebody stayed for 2 days, that's half an hour per day. If they stay for 5 hours, that's 6 divided by 5, which I can't do on the fly. So essentially, the 3% association is with a relatively modest change in staffing. So that's what we get for registered nurses. It's pretty much the same finding that we've seen in the other studies, but this time we are linking the staffing to that individual patient, which gives us much better ability to infer cause. But the other line is quite interesting. That's the association between healthcare assistant staffing levels and mortality. And what we find is that as we move away from the mean, the norm, the level of healthcare assistant staff that essentially that ward planned to have, in either direction, mortality goes up. Too few, unsafe. Too many, unsafe. Very different picture. And one of the things I would say, while I've got some of you in the room, if you want an argument why care hours per patient day is not a measure of safety, this is it. Care hours per patient day combines these two groups whose impact on safety is different. They're both important, but you can't combine them. Staffing at this trust was set using the Safer Nursing Care tool. So there's another inference that we can make here, which is that the staffing plan in this trust worked really quite well for healthcare assistants. But if we assume that the Safer Nursing Care tool gives us the optimum, the best staffing level for registered nurses, we might be wrong. The issue is how much more do we want to invest to improve things? And I've started talking about investment, so let's actually have a look at money. So we modelled a few different situations using these data. So we modelled the effect of adding 1 registered nurse hours per patient per day. And we estimated that in this trust, which had a budget of about £500 million, adding an additional registered nurse per patient day would cost about £10 million. That's to the wards that we studied. That's a pretty big increase in staffing. It's on average 20% of the staffing from current levels on the wards. Although, if you look at norms of registered nurse staffing in other countries, actually the levels that we operate on are not particularly high. If you make an international comparison about developed healthcare systems, we're probably on the low end of things. So it may not be an unreasonable proposition. And we would associate that with about 220 fewer deaths per year. That's 1 fewer death for every 325 patients admitted to the hospital. It is also, whilst £10 million is a large amount of money, I would point out that it is only 2.5% of the hospital budget. It depends on how you choose to scale it. Now, it's a single-site study. We need to be really careful. These results, though, are consistent with economic results that we get from other countries. But I've got another interesting figure to offer you, which is, what if we just tried to run this trust with the staffing that they planned to have? At the moment, they operate with a few more healthcare assistants and a few less RNs than they planned to have. Essentially, let's just call it recruitment difficulties. But if they'd actually just use their staffing plan, there you would get a much more modest increase in cost, because you would have to employ more RNs rather than healthcare assistants. That would be associated with 50 fewer deaths per year. We would also get savings from a reduction in length of stay. And once you put a value on that length of stay, which is a real value, I know it doesn't generate actual money, but it is a real value because we're short of services at the moment, the net cost per patient is actually negative. So this is a cost-neutral intervention that potentially even saves money. We didn't model the effects of increasing healthcare assistant staffing for a very simple reason. We had no evidence that there would be any benefit associated with it. So I can tell you the economic conclusion there. It costs more, and the outcomes are likely to be worse. Now, you are a polite group of people. So you haven't stopped me and said, aha, but these are all just observational studies of association. And association does not mean causation. So don't tell me that you're going to reduce the number of deaths in this hospital by increasing staffing. You can't know that. And you're right in principle. And in case any of you don't understand that technicality, on this graph, what I've done is plot the number of engineering doctorates awarded in the United States against the per capita consumption of mozzarella cheese. And what I hope you can see is that these two are very closely associated. And you could come up with a causal hypothesis about this, but I very much doubt that you'd be correct. However, we can't be certain of cause and effect from an individual observational study for sure. But there is, we need to be able to make decisions about cause from these observational studies because that's all we've got. And there is a whole body of work in epidemiology which addresses the problem of how you infer cause from this flawed evidence base. So I'm going to apply this framework from epidemiology to the evidence that we have, the so-called Bradford-Hill criteria. One of the things they ask is about the strength of association. Well, it's often not very strong, but that's no great surprise. You know, deaths in hospital are multiply determined. You wouldn't expect it to be a strong association. Indeed, I would say that some of the evidence I've seen ought to be dismissed because the reported association is preposterously strong. There's something wrong with it. The findings, though, are replicated across a range of settings. that this is quite a reproducible finding, and the findings are not particularly dependent upon the study designs, so that the flaws in one study don't appear to be what's generating the findings. The strongest evidence we have is about an outcome mortality that's not particularly specific to nursing, but if you look at things that are specific to nursing, like omissions in nursing care, we see the same association. And of course, this has been hypothesized as one of the mechanisms that explains the outcome association. Most of the evidence is cross-sectional, so you don't know that cause precedes effect. But we are beginning to see these longitudinal studies now, and we're seeing the same results. We are seeing evidence of a plausible dose-response relationship, although it's really interesting when you look at UK studies, you don't see it. You don't see benefit tailing off at higher staffing levels. But one of the possible conclusions for that is that we don't have anywhere that by international standards would have what would be considered high staffing levels. And if we map the staffing levels on the UK to, say, the US studies, there is actually often no overlap in the staffing levels that we can observe. There is a plausible mechanism. We've hypothesized that one of the reasons that the mortality association happens is because of the high workloads that lead to omissions in patient care, particularly observation of patients who are at risk of deterioration. And we're now beginning to see direct evidence showing that omissions in care are on the causal pathway between the two. So I think all in all, it's not case closed, but it becomes quite persuasive. The biggest lack is that we have no experimental evidence. And that's often thrown up. Well, this is all associations, it's not experimental evidence. That's absolutely true. But I think the weight of evidence is such that we've got to stop doubting that this is indeed causal. And I'm offering you another body of evidence that was not established by the experimental evidence. In fact, tobacco companies called for experimental evidence on the negative effects of smoking, and for a long time, their defense was the experimental evidence, because the only experiments that could be done were so artificial, they didn't reflect real life, in this case, teaching beagles to smoke. There's always room to question observational evidence. The quote on here comes from the CEO of Philip Morris, and it was published in 1993. So for those who can't read the slide, I'm going to say that again. This wasn't the 1960s, this was 1993. To my knowledge, it has not been proven that cigarette smoking causes cancer. Okay. Well, we've got to make decisions in the face of this uncertainty. And when we're doing this, we have to consider which outcomes are actually more likely. Let's put it another way. Given the evidence and given everything that we know, is it likely that shortages of nurse staffing, or indeed any other staffing group, does not have any negative impact on the quality of care or patient outcomes? And if that's the case, what on earth are they doing there in the first place? So, I'd now like to briefly turn to one of the proposed solutions to shortages in the NHS, which is technology. Great faith in the potential for new technology to increase productivity in health services, and therefore potentially to reduce the demand for health workers. Now, care robots are not with us yet to any great extent, although they are certainly coming. The brave new world may be just around the corner. But what evidence do we have about their safety and cost effectiveness? Absolutely none. Yet they're the solution to our workforce shortage. More Sentry, computerised records and other electronic decision support systems have been with us for some time. Now, this is something that I'm not a great expert with, but I think it would be fair to say the jury's out the extent to which electronic patient records and other systems deliver improvements and efficiencies in care. If any of you think that these benefits are axiomatic, I'd urge you to have a look at an article by Atul Gawande in the New Yorker that was published, I think, in November, and it's called Why Doctors Hate Their Computers. It's a source of lots and lots of quotes, but I'll give you a sort of an account from an office assistant, an assistant to a doctor. Previously, she sorted the patient records before the clinic, drafted letters to patients, prepped routine prescriptions, all tasks that lightened the doctor's loads. With the introduction of a new electronic system, none of this was possible anymore. The doctors had to do it themselves. If you look at the research evidence around this, I think it'd be fair to say it's decidedly mixed. There was a study that showed that staff time spent documenting increased initially by 50% after the implementation of an electronic patient record. It returned to baseline after about 18 months, so that's good, but that was partly achieved by the dropout of physicians who found the electronic patient record difficult. Now, to me, that reads like the problem is not the system, it's the staff. It's not compellingly a solution to workforce shortages. Now, I'm talking a bit too slowly. No, I'm saying too much. That's what I'm doing. Speed's probably about right, but I'm saying too much. I just want to briefly touch on evidence in other fields. We've seen similar studies in intensive care, in A&E. We've seen hospitals with more cancer specialist nurses having better patient experience. Nursing homes with more healthcare assistants and registered nurses have better patient outcomes. General practices with more practice nurses have better chronic disease management. Mental health hospitals with more nurses have worse conflict and containment rates. An interesting finding that, if nothing else, should remind us that we should never take one study and rush to infer cause. But for the body of work as a whole around hospital nursing, I think we can take the causal argument as read. The biggest problem with all this, though, is it boils down to a request for more. And that's the problem. It doesn't actually tell us how many we need. It just says that we need more, that more is better. Now, over the years, we've put a great faith in the use of evidence-based staffing tools to give a more efficient patient allocation. And I'm going to give you the unadulterated version of this. And I'm not saying that they're a bad thing, but actually we have very little evidence for them. And it's really interesting that people and bodies who shall remain nameless that are quite happy to point out all the limitations of this big body of research associating nurse staffing levels with patient outcomes are quite happy to accept the benefits of using staffing allocation tools, when the reality is that evidence base boils down to a bunch of studies that show that one measure of staffing requirement is associated with another. That's about as far as that evidence goes. What I would say is I have quietly and perhaps accidentally slipped in some of the most robust evidence that there is for the Safer Nursing Care tool, because we've shown that in a hospital that uses the Safer Nursing Care tool to set their staffing plan, if they were able to achieve that staffing plan, that would be cost effective in relation to what they're having to do because of nursing shortages. And with that, sorry, I've missed a slide. With that, I'm going to turn to another proposed solution to the registered nurse shortage, the nursing associate. And of course, this is an area on which we don't have an evidence base because there aren't enough of them really to understand what happens in practice. But based on the evidence that we do have about related issues, applying a principle of decision-making under uncertainty, the likely outcomes depend on which of these strands of evidence actually are most relevant to the development. All of them suggests that there are risks, but there are risks in everything. All of the evidence points towards us needing or benefiting from a larger, better educated nursing workforce. Only a net upskilling of that workforce presents any realistic prospect of improved outcomes. And even then, it is likely to be a relatively expensive solution compared to registered nurses. Now, I'm going to leave that slide up while I just say a few concluding remarks, although appreciating that people at the back, again, probably can't read it, so I'm sorry about that. I'm going to return to the magic number. I know that there's so much more to safe staffing than numbers. I know that leadership, positive work environments, cultures are vitally important, and there's ample evidence for those benefits. But these things are complements to an adequate workforce, not substitutes for it. And I think we sometimes forget that. I also know that it's really hard to maintain those things in the face of staff shortages. And I think this is where we get to the real problem. I alluded to tobacco control research earlier, and in some ways it may not be the best metaphor here. With tobacco control, we know exactly what we should do, and unless you happen to be running a tobacco company, the risks of doing it are pretty low. You get people to stop smoking. What's the harm? But perhaps it isn't such a bad metaphor, because I think the difficulties in achieving the goal of a full complement of professionally qualified nursing staff shouldn't divert us from the fact that that is a desirable goal. It's well supported by evidence. Working towards any other goal is fraught with risk, and so at the very least we need to proceed with a proper risk mitigation and risk monitoring strategy. It may well be that technology can reduce the demand in the end so that the full complement is less. But technology in healthcare is notoriously expensive, and all the evidence suggests that it doesn't replace professional staff, it actually passes a burden from administrative support staff onto professional staff. So the solution to a shortage of well-trained and highly qualified nurses is probably more well-trained and highly qualified nurses. And I realise that that leaves many of you in the room with a bit of a problem. But at least we do have an evidence-based solution, which we often don't. Everything else at the moment is wishful thinking. It might be characterised as the triumph of hope over expectation. I'd rather say it's a product of accepting the current bad situation as inevitable, and I don't think it is. Change will not come fast, but change can happen. It has happened in the United States, for example. I think as a profession, as a service, we can do better. And just one little line at the end. There are a number of professions represented in this room that have been largely excluded from everything that's been said today, not just me. And I think my conclusions about nurse staffing are directly about nurse staffing, end of story. But if you think that evidence like this might be useful to your profession, there's only one of me, but I'm all for joining you in trying to move this along, because it is vitally important, and I think we know that. But if we've got a problem with the evidence about nurse staffing, there is so much less for any other profession. So, thank you.